So my name is Paul Dixon. I'm a consultant orthopaedic surgeon, so my managerial background is negligible to say the least. Which I guess is why I'm going to talk a lot about patient care and probably gloss over the pathways to a certain extent. But I'll do my best if there are any questions. We had an extended team working on this project. 5 members of the team are here today. Any of them will be keen to answer questions, I'm sure. Hip fractures. I've always considered that hip fractures were the forgotten patients within orthopaedics. When I was a houseman 20 years ago, my first experience with a hip fracture patient was I'd just done 6 months of medicine. I turned up on the orthopaedic wards and I was asked to see a patient in crashing heart failure. They'd been seen by the previous houseman who'd done their best. I came in having done 6 months of medicine and did a little bit more. And the nurse who was in charge said, I'm so glad that I really like it when people rotate and they've done some medicine before. At that point I realised, as the houseman with 6 months experience, I was going to be the most senior physician that saw this patient. Now luckily, over the last 20 years, things have changed. And there has been an impetus, particularly over the last 5 or 6 years. In 2007, the BOA, British Orthopaedic Association, and the British Geriatric Society launched a blue book which set out standards of care for hip fracture patients. It recognised that things needed to change. And I think it's very salient today, given the headlines on the front of the Times that I've just seen in the foyer. Recognised that this wasn't just about a broken hip, it was about the patient attached to that hip, and the complexity of the fracture was really, to a certain extent, not relevant until you'd considered the complexity of the patient. And there was a cost, both in human and economic terms, to the NHS, which could be improved. And these were are the framework which the Blue Book was based on. The 6 key standards: patients getting to wards quickly, being assessed quickly and being operated on, being seen by senior care of the elderly physicians, being assessed in terms of their need for secondary prevention, pressure ulcer care, and that the whole thing should be multidisciplinary. Things moved on apace, and in 2008, standards of care for trauma were published through the British Orthopaedic Association. There was an evidence base to these, and the principal thing was it recognised the frailty of these patients, both in terms of their bone, but probably more importantly in their general health. And 50% of these patients have severe cognitive impairment, so they can't actually speak for themselves. And that, I think, is a key thing. It also very much pushed the multidisciplinary approach, which was something that was a bit new, particularly to orthopaedic surgeons, because we're not good at working with other specialties. And they put in a 14-point goals for care, which again was fairly ambitious because orthopaedic surgeons can't count over 10. This is actually revised in 2012 to make it a little bit more simple, and it's down to 12 points now, 13 points. And things shifted a little bit, talking about appropriate first aid, control of infection, communication, rehabilitation and discharge planning. And the key thing was the National Hip Fracture Database, which has now become mandatory that every patient who has a hip fracture treated in the NHS, their details have to be put into this database. So we now have a yardstick to see how we're performing and how possibly care is improving. In Sunderland, we've been putting data into the NHFD since 2008. We see 400 cases a year, so this isn't a small group of patients. And as I say, we're able to benchmark our against standards and our peers. And it also gave us an impetus to appoint an orthogeriatric nurse practitioner who's been working in the department for nearly 5 years now and is here today. But the real impetus in terms of focusing things was the introduction of the best practice tariff in April 2010. So the quality of the care we provide was linked to the income that the trust got. And this was all based on the NHFD data. Each year, the gap between achieving best practice and not achieving in terms of payment, that gap has increased. And each year, the goalposts have got a little bit further away and it's become more difficult to meet those targets. So there's had to be a sustained improvement. And it was the introduction of the best practice tariff that gave me the real drive to go and see the managers and say, look, we need to improve. And because it involved finances, I was able to just keep hammering on the door. And things did change. It really raised the profile. So agree with it or not, it has had an effect. So end of 2011, I went to our new divisional director and we sat down and went through things and came up with some goals. We wanted to develop a robust, sustainable, multidisciplinary approach that was reproducible for every patient, so that we got rid of our outliers and everyone followed a very similar pathway. In terms of standards, they'd been set out for us, so it was there already. We had a problem with length of stay. We still do to a certain extent, and there's very much a drive to decrease that stay. And obviously, there was key wanting to improve that income from best practice tariff. This is the bit I'm going to gloss over. I insisted that the whole process had to be patient-centred. This is the Sunderland house. I understand it's based on the Virginia Mason thing. And we had a continuous improvement facilitator who came and explained it all to me. I promptly forgot. And he said, right, what we need is a team. Who do you want in your team? And we went through the medical team, nursing, physios, OTs, social workers, managerial involvement, and we managed to get a whole team together of people who were interested and wanted to be involved. And the whole point was that the best practice was secondary, my point being that if we did things well, best practice would follow. Graham Miller, who is the facilitator, he organised everything. After he'd identified the team, he sorted out the invitations, he came up with the charter. I organised a 1.5 or 1.5 day workshop, RPIW type event. It was going to be 3 days, it went down to 2 days, and then 1.5 days because trying to get everyone together in the same place was a real hard. But 1.5 days turned out to be pretty, it kept everyone focused without drifting off. We went through a process of identifying, well, looking at the pathway we had at the moment, looking at how we'd like it to improve, identifying what was stopping that improvement, and coming up with a plan as to how we could overcome those barriers. And organise a 30, 60-day and 90-day review as per RBIW guidelines. The process was mapped. Again, Graham follows it all through. Different members of the team identified each step of the pathway, what their input was, and we looked at ways that we could improve that. Came up with an action plan. That's just part of the action plan. It went to 3 sheets of Excel, but the traffic light system allowed us to identify at the follow-up workshops where we got to, where the barriers were for that. And it actually, you know, being a sceptic when I came into it, it did actually give us a progress to follow. And I, to a certain extent, I'm a convert. When we'd gone through the process mapping, there were some key target areas that I felt we could improve. The time to surgery, getting patients seen by a care of the elderly physician. Our pressure ulcer rate was running at twice the national average, which very much concerned me, and I wanted to decrease that. we looked at the inpatient stay, because as I've said before, that was higher than it should have been. And I was also very keen that this should be patient-centred, and as I said, with 50% of the patients being impaired cognitively, that we had to involve families as well, because a lot of the time the patients didn't know what was going on. And our engagement I think it had always been poor in the past. So as far as time to surgery went, we identified that a lot of patients weren't getting to surgery because they weren't getting their investigations in time. And what we managed to do was we managed to get A&E to do the investigations at admission, rather than the patients having them done when they got to the ward, which put a 4-hour gap into the system. And it took a little bit of persuasion, but patients started getting investigations earlier, which meant we got results earlier, which meant the results were there for the anaesthetists. We were asking the anaesthetists and the care of the elderly physicians to see patients sooner, to alter the way they were coming to the wards. And the anaesthetists agreed that they would, for the most part, be coming to the wards half an hour earlier than they used to. And we have a very dedicated set of trauma anaesthetists, and they were there, often before I was, to my shame. So I had to get up earlier. The other thing we did is we resuscitated the patients more aggressively. People had always been wary about these frail elderly patients, giving them fluids, that they might put them into failure, overload them with fluid. There's a lot of evidence that if you give people quick fluids but appropriately and monitor it, it's actually good resuscitation rather than overload. So we took away the worry of the junior doctors that they were going to put these patients into heart failure by educating them. At induction, the junior doctors were given the resuscitation guidelines. The anaesthetists came and spoke to them. The care of the elderly physicians came and spoke to them. And we got over that to a certain extent. We also changed the way that theatres ran. The trauma list historically was always morning and afternoon affair, but we altered it so it could run all day, and it became more flexible so we could slot patients in as they were deemed fit. And with buy-in from the anaesthetist, we were able to start putting a list of patients in for the day, but not necessarily in the order they were going to go. And that took a little bit of work and a little bit of sitting down and talking, but gradually it became standard that we discuss patients at the beginning of the day and feed them in appropriately. And for a lot of my colleagues, the concept of hip fractures being done first on the list rather than last on the list and left for the registrar was very alien. But with this impetus, we managed to persuade them that they should be done first on the list, always with a consultant either in theatre or immediately available. And there's been a mind change, and it hasn't happened overnight. There's been an ongoing drive. But things have improved. Initially, when we started the project, patients were taking 38 hours on average to get to theatre. By 6 months into the project, that was down to 25 hours. And the number of outliers had decreased as well. So, definitely a positive, and things moving in the right direction. Historically, care of the elderly, we had one consultant who was on the ward 3 times a week. So basically what we needed was bodies on the ward more often reviewing these patients. And once we've been able to convince the clinical director that this is what we needed, he went away, he looked at job plans, he played with timetables. There's still ongoing arguments about who funds what, but funding issues to a large part were sorted out, and a consultant was available every weekday morning. Initially, we now have intermittent 1 in 3 weekend cover as well, which has very much improved things. The other thing we did is we actually told the care of the elderly physicians who we wanted them to see. It seemed to be very ad hoc before. And Keely in her role was taking them to who she wanted to see, but she only works 4 days a week. So the other 3 days, no one was actually guiding them. So we managed to simply, an A4 folder, list of names that we wanted the care of the elderly physician to see, and they would go up and see them and communicate back within the same format. Very simple little things. And again, things improved. It was taking 47 hours on average for a care of the elderly physician to see a patient. That came down to 34 hours and has improved even more over the last few months, which is just as well, because the new target for best practice starting in April is that every patient has to be seen pre-operatively. So we're going to have to adjust the way we do things again. As I said earlier, the pressure ulcers really worried me, and it was something I wanted to see decrease. We identified that a lot of the nursing staff weren't assessing the patients quite as appropriately as they might have, not realising they're at quite as high a risk as they were, and we didn't have as much access to the specialist devices such as the repose heel protectors and the pressure area mattresses that we'd like. Again, weekends were identified as an issue, getting hold of the mattresses at weekends. These patients can develop pressure area problems within 12 hours. So 48 hours over a weekend was too long. And all it took was ringing the company and saying, "Can you give us mattresses at weekends?" "Yeah." "All right then." We'll have them. And it didn't take much at all. And suddenly we were able to have 7-day access. A lot of these patients are malnourished. We looked at nutrition bundles, and every patient is now given protein supplements from the moment of admission as part of their admission prescription. And we also changed the way we mobilise these patients and got them out of bed earlier, moving around the bed, introducing the S-Skin bundle, which basically focuses the nurse's attention on pressure ulceration and gives them a format in which to assess and work, so that patients are getting turned more often, and incontinence, being a big issue in these patients, is addressed early with early catheterisation. And apart from a blip in August of last year, when we had an issue with mattress availability through a procurement issue, which I don't still fully understand, there has been a trend where the pressure ulcers are gradually decreased. We've now had 2 months where there were no pressure ulcers at all, which was virtually unheard of before. In Sunderland, there's always been a very them and us approach between the healthcare profession and the social services, and I felt there was very much a barrier, and I think it was something that the social services found as well. I sat down with the head of social services, an unheard of interaction between the clinician, and they identified 6 beds that potentially they could earmark as rehab beds, which previously we knew nothing about. They also told us that there was a new facility just down the road, which was opening in September of last year, which we could have access to. All we had to do was ask. And suddenly we had this rapport going, and we were able to get the social workers onto the wards, and with a lot of problems from our IT department, but barriers that were overcome, we were giving them access to our electronic record system, so they could see what was happening in the clinical pathway. Unfortunately, that's now been withdrawn because of information governance issues, which again I don't fully understand, but we're working on it. We never really planned discharge until patients were ready to go home. And now all we've done is start planning discharge at the time of admission. So patients are coming in with an estimated date of discharge. That's a flexible thing, it can change, but it gives goals, and particularly as part of the rehab protocol, it gives a goal for when we want the patient out of hospital. And we've also given the patients and given their families a list of expectations, what we'd like to see an individual doing on set days, when they're going to get out of bed, when they're going to be up with a frame independently, when they're going to go home. People respond to having a target. It's been gradual, with blips in July and August last year, which I can't really explain. It may be something to do with the holiday period, I'm not sure. There is a trend that the length of stay has gradually come down, and it's come down by an average of 5 days, which in monetary terms is huge. And it's also meant that there's less pressure on our elective beds. So we're getting the elective cases through, rather than cancelling on the day because there's no beds. That has become less of an issue, unless it's icy outside, or very windy. Ignore the January 2013, because some of those patients are still in, so that's a bit of a... we haven't suddenly got brilliant. And as I said, I was very keen that we had a degree of communication and engagement, and we increased that, so we've introduced a patient information leaflet, which gives patients and their families realistic expectations, and to a certain extent sets out the goals. We now are far more encouraging families to be involved in their relatives' care, and asking them to come in to help with feeding, to help with mobilisation as and when needed. We've also made the consultant medical staff put notices up that we are available if patients or families want to talk to us, and the best time to catch us is at 9 o'clock in the morning when we do ward rounds, and the senior nursing staff are going around every day to speak to the relatives. I've also introduced, as part of the NHFD, cognitive testing on all these patients. They're supposed to be assessed at admission and post-operatively, but we're trying to do it on a daily basis to get an idea of the mental state of these patients and how they're absorbing the information they're being given. At the moment, we haven't done really any formal assessment of this, and I think that is a deficiency. But informally, the feedback is very good, and the number of complaints has nosedived, which is nice to see, because complaints generate work when we could be on the shop floor. Two other things that have come out. Mortality has decreased. The NHFD over the last year has measured 30-day mortality, and our 30-day mortality appears to have nosedived. Now again, I think there is a slight pinch of salt with this, because patients admitted in January of this year are still within that 30 days, and so that graph may not be as spectacular as it appears to be. But the in-hospital mortality has also come down. That is a far more gradual thing, and I wonder whether we're doing things really well now at the beginning of the patient's journey, but we're not sustaining that through their whole inpatient stay. As an orthopaedic surgeon, my priority is to get the patient resuscitated, get their fracture fixed, and get their wound healed. But these patients, as I say, they have complex comorbidities, and that's way outside my skill mix. And we need that continued care of the elderly input, and that's where our drive very much is now. As far as best practice tariff goes, as we prophesied, we've got better, and without really trying or aiming at best practice, it has improved. And it's gone from just over 60% now to about 75%, which in a year with 400 patients, extra 60 patients, over £1,000 a patient, potentially is an income of over £60,000 an annum, more than it would have been otherwise. Everyone's happy about that, particularly the Chief Executive. So for the future, I think very much we are putting the drive on the care of the elderly. We're trying to get 2 extra care of the elderly consultants so that we can have a fully integrated unit with not only a care of the elderly consultant there in the morning, but there all day, 7 days a week, and providing continued care with follow-up, ongoing care. And I think that has to be our focus over the next year. We do need to look at the patient feedback, some family feedback, and from the 1st of April it's going to be compulsory to have family and friends tests. We've rolled ours out this week, and I hope that that will give us some positives. The dementia element is key, involving families when these patients are identified early, and also providing an environment that's appropriate for these patients. So we are looking at ward refurbishment and making it a more friendly atmosphere, for want of a better term. And with the extra community rehabilitation that we've now got available, we're looking to improve the use of that and potentially send patients earlier with senior medical involvement from within the hospital, going out on a daily basis, whether that's myself as an orthopaedic surgeon or the care of the elderly physicians, to actually do ward rounds there and make sure that things aren't being missed. Thank you.
So we've got any questions from Paul? Yep.
Just going back to the social work now, do you actually manage to, or social services, do you actually manage to discharge the patient before you're medically fit? Actually refer the patient?
We managed to refer them on a daily basis. They were holding, and still are holding, MDT meetings, powwows, on our rehabilitation ward. So the social workers weren't officially allowed to put them on their books,
Right.
but unofficially they knew they were there and they could start the ball rolling without the formal paperwork. And then the moment we said medically fit, it was all set up and ready to go. So it was a bit of a fudge, but we got there. Yes.
Thank you.
Yeah, hi, thanks for a great presentation. It was really great that you're showing your mortality rates, and I just wondered, as a clinical team, especially given that you span several teams because of the complexity of the patients, whether mortality rates of patients that have gone through the care of that team are actually looked at by the team.
As part of this, we instituted a monthly M&M, and I chair it. The care of the elderly physicians come. Matthew, who's in the audience, who's an anaesthetist, is there, and the nursing teams, and we do review all our M&Ms as a multidisciplinary, and then that's the anaesthetists actually do a separate M&M of their own, and they feed into that with their observations as well. It's working pretty well. We don't pick up every patient because quite a few of these patients, due to their complex medical problems, actually go to other parts of the hospital and unfortunately die there, and we don't know it's happened. So we're looking at ways, now we've identified that that's happening, we're looking at ways of making it so that we can include them all. And that may be where the NHFD can help us, because they can record 30-day mortality. There is a lag of about 2 months, but we do know those patients have died. So it's nice to review these cases fresh, or as fresh as you can get them, which is a little bit of a worry of mine. But in catching those we've missed, it will help. So you've got to get the balance, I think.
And it's also taken to that level of doing the root cause analysis as well, isn't it?
Yeah, it's not something you can do quickly. These are complex patients, and you've got to go through the complexities. And a lot of them, unfortunately, do go to the coroner, and we do have problems getting hold of notes when the coroner's involved and getting post-mortem results. But we're getting there. But it's harder than you think.
But it's great that you're really including that. So.
Excellent. So we've got a point up there.
Really enjoyed the presentation, thank you very much. Described a real complex situation, and you've got a clear kind of forward plan in your head that you're aiming toward. So wondering how are you managing to keep everyone else on board and aware of where you are in that plan and what you're focusing on as the next element?
I'm very lucky that I have a very good team, and we have a trauma coordinator and our orthogeriatric nurse and the ward manager who all work very closely with me, and they're in a much better position to spread the message than I am because they interact with everyone. And each month we sit down at the same time as we're having the M&M meeting, we'll review what has happened the month before, what the trends are, and we'll set a focus. And they go out and spread the word. And I don't do an awful lot, to be honest. I rely very on they feedback directly to me. So I've got them to thank for making sure that we keep moving on. I hold my hands up, and I'm not doing this alone by any stretch of the imagination.
Well, you sound so modest. I think you're the chief fixer, aren't you? You sort things out.
Well, I fix the fractures. Yeah.
Brilliant. Thank you. Thank you very much for